Here we are, Pedrito. I call my friend Pedrito because it's much more easy for me to pronounce his name in Spanish. But let's go to the topic. The use of ultrasonics in dentistry in general, but mostly in endodontics, is quite convenient and is quite useful because in some cases we want to preserve that healthy structure that is remaining on the affected tooth. We as endodontists, we need to treat with severely destroyed uh, teeth, like in this case. As you can see, this molar have a severe destruction. We need to preserve all the tissue, the healthy tissue that we can, as much as we can. And as you can see, we do not have here a pulp chamber. We have that absence of pulp chamber, and we need to look for a convenient way to go and look for the canals. Locating the canals is very important because one of the main causes of failure is the persistence of bacteria inside of the root canal system. That bacteria persistence can be related to a non-treated canals. And the ultrasonics can help us to locate that canals that sometimes are covered by tertiary dentin. And with the help of ultrasonics and with the help of all the protocols, all the pre-endodontic protocols that we have in the office, it's possible to go from a situation like the one that you are seeing in the left side to a clinical situation that like the one that you are seeing in the right side of the screen. And it looks pretty different, and it's the same molar. It's the same molar after removing all the caries, all the affected tissue, after removing all the tertiary dentin that was covering the the pulp chamber. And in this case, in this particular case, we were able to locate the four canals, and we were able to achieve a successful result, as you are seeing here. This picture looks beautiful. We didn't touch any part of the floor at the floor of the pulp chamber, and we think that this treatment is going to be successful. And this is in the best scenario, but sometimes we need to treat cases as well with calcifications, like the case that you are seeing here. This patient went to the office and with a lot of pain. It was a tricky diagnosis because the patient was responding normal to all the sensibility tests. We tried to have a precise diagnosis, but it was quite difficult. The patient had an irradiated pain in the area. It took around 20 to 30 minutes to identify that was this first molar the cause of the main source of the pain, of the problem in the patient, and we started to do the treatment. The first thing that we did was to remove this previous restoration, this amalgam. We do a class 2 restoration in the premolar, and then we reconstruct this molar, because it's very important to have that contact point in a proper way to protect the periodontal tissues. So as in every case, we decided to go the more conservative we can. We were able to locate the MB2 canal with the help of ultrasonics as well, but almost when I was finishing the shaping of the root canal system, I was working in the MB2 canal. I were able to go smoothly with a 2506 file inside, and then I think, and I decided to go inside with a 3504. And something in my mind tell me, like that little angel that tell you do not do it, And I have that voice in my mind that tell me, Jenner, don't go inside with that 3504. And I just decided to go inside and I broke the file. I broke the file. You can see the broken file here in this area. And as you can see, I decided to finish the treatment in this way. And I just decided to leave the file inside of that root canal. So at this point, we are not finishing with my with my presentation already, but I would like to hear about your opinion on this topic, Pedrito. What do you think? It was a wise decision to just leave the file there? You think that it might be advisable to go and remove the file with a surgery? Maybe try or the attempt to remove the file through the root canal could be a better decision. So what do you think? What is your personal opinion here?
Okay, one more time. Sorry.
Yeah.
I got exactly the same opinion like you. Sometimes when the file breaks inside the canal during the shaping protocol and is located in the apical third and it's like lock the apical foramen, it is not good idea to try to remove it when we don't have periapical lesions. So I think the most important factor, if we can have a success with the broken file inside the canal or not, is the presence of periapical lesions. So when we have periapical lesions, it is difficult, more difficult situation, and maybe apicoectomy will be the solution. But I will probably do the same. I will obturate the canal to the broken file, and then just take some observation for 6 months maybe. When the healing process will start, I will do nothing, just observe the clinical case. If the healing process will not start, or we will have some swelling or pain, that will be the direct indication for apicoectomy. And this is a beautiful case with the conservative approach of preserving some coronal tissue of this tooth. And the anatomy of the MB canal is difficult because it's curved. It's not extremely or severely curved, but still the broken file is behind the curvature. So if we want to remove it orthograde, it will be total destruction of the root MB root dentine structure, because we need to see the broken instrument. To see the broken instrument under the microscope, we need to straighten up the curvature, which means we need to remove a lot of dentine surrounding the canal. So after this procedure, the root will be weak, and it might broke in the future. So for this case, I think is the best scenario to leave this broken instrument at the apical part, obturate to this broken instrument, and just do the checkups after 6 months, 1 year, 1.5 years. And I'm sure that everything will be okay, because it was not the first file in your I don't know protocol, shaping protocol. So before this file, you got already some other files that cleaned the canal. Also got for sure some sodium hypochlorite during the shaping protocol. So I'm sure that the canal was also disinfected properly before it happens. So I think you choose the best option here.
Yes, great. Actually, I started with this case because a lot of people thinks that having a broken file inside of the root canal is it just the beginning of a failing case in the future, and it's not in that way. We are not saying that uh, it's not bad to broke a file inside of the root canal because nobody wants that. But you touch very important points. One of them is that the file that is broken inside of the root canal is very important. It's not the same to broke a 15 file than breaking a 3504 in this case, because you already mentioned that by that time the root canal system was already disinfected. So it's not going to be a problem. It's very important to have in mind if the case necrotic or it was a vital case. If there was a periapical lesion, we need to remove the file in most of the cases. And the location of the broken file is very important because I have seen many cases in Facebook where in social media in general, where people proudly show how they were able to remove a file. But when you check the final radiograph, the coronal structure is totally destroyed. So we might provoke more damage than benefit to the patient. So let's see what the literature says about the topic, and I will go back to the presentation.
Okay.
And look at this study. This study is very interesting because it's a systematic review, a very good impact rate of this scientific article. And what this article says is that the prevalence of separated instruments goes from 0.5 to 7.5%. It means that every endodontist, every dentist around the world uh, is in risk of broken a file. It have been a problem since the beginning of the root canal treatments, and we're still facing that type of situation. But the most interesting part of this review is that the success rate going from 1 to 4 years follow up, talking about teeth with broken file, is 91%. The success rate is very high. And the success rate reported for the controls, the teeth that were treated without any instrument inside, was 92%. It does not mean that we will leave all the broken instruments inside of the root canal, because if the broken instrument is an impediment to go inside and to clean and shape the complete working length, of course we need to go inside and remove that instrument. And you, Pedrito, already mentioned a is pointed in the conclusion topic. Conclusion says that the prognosis is lower when a periapical pathology is present. So if there is a periapical pathology and the clinician broke an instrument inside of the root canal system, the chances of or the possibilities to have a successful case are going to be reduced. And we are going to see a few cases in where we needed to remove the instrument from inside of the root canal. I think everybody have a protocol for removing a broken file. I have my own protocol, and this is like a hybrid protocol that I create since I started doing my attempts to remove files inside of the root canal system. I use the Micro Explorer from the Terauchi file removal kit. I use the Aurum Blue file, the opener, that is file 25 with taper 10. I use the 3504 to create that coronal enlargement. That is very important for being able to see the broken instrument. I like to use the ultrasonic tip from the Terauchi tip as well, because it's very long and it's very small. It's important to use these instruments for removing files with a very small power in the ultrasonic unit. And these ultrasonic tips from Endostar are very useful type as well for removing and to expose the coronal portion of the broken file. As soon as the broken files of the root canal, I use the BTR pen. I use the loop technique to grab the file. With this system, I'm able to grab very tight the file and to take it out. And we will see a few cases where I apply this technique. In this case, for example, this is a second lower molar. I broke an XP endo shaper. The good point about this file, the XP endo shaper, because of the shape, is very easy to bypass. So as you can see in this radiograph, I was able to bypass the file. At some point, I think, okay, I already bypassed the file. I already were able to clean and shape, and I just thought by that time I will go inside and obturate the canal. But when I was about to obturate the canal, I noticed that the file was very visible. The file was loose inside of the root canal, and I said, okay, I will go inside, grab the file, and take it out. You can see the file was located here. This canal, the shape of this canal was already, the canal was in this shape already after the cleaning and shaping. I do not remove that dentinal tissue trying to expose the file. I just bypass it, I clean it, but the file went and get a little bit stuck in an isthmus in the area. And this is the final result. I managed to grab the file and to remove the file. And as you are seeing here, I cover the entrances of the other root canals with a flowable dam. I like to use a flowable dam that is it has a blue color. It's very easy to see, it's very easy to place, and we avoid the risk of taking out the file. But sometimes if we are not covering the entrances of the root canals, the file can go inside of the other root canals, and it's going to be a nightmare. And I think I have one video here for showing you how we managed to remove the broken instrument. It's the same molar. We started removing tertiary dentin in the entrances of that root canals. This is an ultrasonic tip. Because of the location of that file, I decided to prevent the ultrasonic tip to make the tip, the broken file, to be loose inside of the root canal. And now I'm going with the BTR pen to grab the file. It's just a matter of tightening the loop and to gently take the file towards coronal. And you will see how the file is going out. It was a big fragment. It was a very long fragment. When the fragment is long, it's much more difficult to take it out. If the fragment is small, sometimes it's just needed to use the ultrasonics, and the tip will go out from the root canal system. This is another case. This case was referred to my office. This case was very interesting because, and it was a very difficult case to deal with, because as you are seeing in this radiograph, the mesiobuccal canal was not treated. it seems that we have a broken file, a long broken file in the distal buccal canal, and we started removing the first fragment of of the broken file here, but by our surprise, after removing one fragment and after cleaning the coronal area of the root canal, we located a second fragment of a file broken inside, and our guess is that maybe the practitioner, in the attempt of removing that broken file, he tried or she tried to bypass the file, and they just broke another instrument inside. And it's something that can happen. When we are trying to remove or to bypass a broken file, we are always in risk of breaking another instrument. We are in risk of breaking ultrasonic tip. Broken the ultrasonic tips always is a thing that always happen in our attempt to remove that files. And this is the big fragment that we were able to see in the initial radiograph. With these big fragments, when the file is strongly attached to the root canal walls, it's kind of complicated. It's a complex process to make that file get dislodged from inside of the root canal system. But if the clinician is patient and if the clinician use the proper tools and if the clinician use small instruments for trying to expose that coronal part of the instrument, the process might be successful. And let's see the video of how do we manage to remove that big fragment of the file. I think the length of that broken instrument was about more than 10 millimeters. We need 2 appointments for finishing that treatment in that molar. But as soon as the file is loose inside of the root canal, it's possible to remove it. And now we have a clean and we have a permeable path inside of the root canal to go inside and to be able to clean and to disinfect everything inside. Look at this file fragment. It was very big, and as you can see, as we already mentioned, we can see that small edge was created in this area. We need always to think if our attempt to remove the file is going to remove too much dentin. If we are in risk of removing that coronal dentin that is very important for the long success rate of the tooth, is better to decide just to leave the file and to observe, because having the patient in regular controls, is another way of taking care of a broken instrument, and then analyze all the possibilities that we might have to accomplish a good result in our treatments. This is another scientific article. This is another article that was published recently by Spilly and is related to broken files as well. They have a very big sample, more than 8,000 tooth with root canal treatments. From all that teeth with root canal treatments, more than 200 were reported with separated files, and the percentage of teeth with separated files in this case, in this report, in this article, was 3.3%. The percentage of files broken inside of the root canal was above 78% for rotary files. In most of the cases, we will break rotary files. because of the way of working inside of the root canal. In most of cases, the failure will be related to a cyclic fatigue, and sometimes it might be related to a torsional fatigue, but the cyclic fatigue is our main problem. And the success rate after 1 year success rate, after 1 year is just too small. I think we need to see recalls of 4 or 5 years maybe. But for having an idea, the success rate for teeth with broken instruments inside was 91.8%. And for the controls, the teeth without broken files inside was 94.5%. So the success rate is still being good, and we are in concordance with the results reported in the previous article. But we are seeing the same situation. The less success rate was reported in teeth with periapical disease. So we need to analyze different factors. And just for finishing with my part, I want to show you this video. This video is about the complete process of and for removing a broken file. Very important, we need to see what we want to remove. If you are not able to see the head or the coronal part of the broken file, it's not going to be possible to remove it. Now we were applying some ultrasonic forces to that broken instrument, but at some point I broke the ultrasonic stick. You see that metallic tip that is coming out from the root canal? It's the broken part of the ultrasonic tip. Then we continue with another ultrasonic tip. We managed to get the file loose inside of the root canal system. We like to use one endo aspirator that is very small, and we can go inside to get dry the area and have a proper vision of the broken file. And we started with gentle tracking force to take out the file to the coronal area. This is the broken instrument. As you can see, it's a very long fragment as well, and we managed to accomplish a successful final result without compromising the coronal structure. That coronal structure is very important because, as you know, for considering a root canal treatment successful, we need to have a proper coronal restoration. Without that coronal restoration, we cannot say that the root canal treatment will be successful, because we need to keep a proper sealing in the coronal area of the tooth, and we need to have a proper sealing in the apical area. In that way, we will keep the bacteria away from the nutrients that will activate the metabolism, and in that way, the remaining bacteria inside of the root canal is not going to provoke any disease. So, what do you think, Pedrito? What are your comments about the technique that we applied in my office? Is similar to the one that you use? It's different? Any advice? Any comment on one of the cases? Let us know.
You showed the beautiful cases. I also got this BTR pen in my office, and I use it a lot. But sometimes the canal is so narrow that if we don't want to enlarge it too much to have a space for the wire loop on the end of the needle of the BTR pen, we can consider some other options than the BTR pen, some homemade usage of the needle. So I will present in my part of the presentation, let's say, homemade injection needle, modified injection needle technique. that can also be very conservative for the dentine in the coronal part. For sure, it's the cheapest technique of removing especially long files, because as you mentioned here, very important thing, short broken part of the instruments we can remove just with ultrasonic. It just release a little bit from the surrounding dentine, supply and add some ultrasonic forces, and it just jumps out and disappear from the ultrasonics. But if the broken part of the file is long, I mean 4 millimeters and longer, and the canal is even slightly curved, it is sometimes impossible to remove it just with the ultrasonic. We can lose this broken file inside the canal, but we are not able to remove it from the canal. So we need something to grab the loosened file inside the canal and take it out. So BTR pen is the great solution, but also you can do this with homemade modification of the injection needle that I will present in my part. And also don't be afraid of using ultrasonics. As you mentioned, all ultrasonics are just wires that transmit the ultrasonic energy, and they are breaking because of this energy. But when we break some ultrasonic tip inside the canal, it is loose inside the canal. It's not screwed into the dentine. So it's quite easy to take it out from the canal. You showed this on the last video that you just take a Explorer, I think it was Explorer, and take it out from the canal without any problems. So we don't need to be afraid of the broken ultrasonic tips during the procedure inside. But I will also show two different options of the ultrasonic tips. One is more aggressive to the dentine, one is very predictable and can remove the dentine very precisely from the area that we want to remove. If we want to be more conservative, and if we don't want to create a huge ledge, because as you also mentioned at the last case, every time we remove separated instrument from the canal, we create a ledge. Sometimes it's a small ledge without any problem, and rotary file that will shape the canal after removing the broken instrument will smooth the ledge, but sometimes it requires some additional work to smooth the ledge that we created during the procedure of removing broken instrument. So now I will present you the technique that I want to share with you and the knowledge about it. And then we can discuss and compare these techniques together, because many of the points and the key points, milestones are exactly the same, but the equipment is just different. But the idea is exactly the same.
Great. I would love to see your presentation.
Okay, so just let me play that presentation. As you said, it is important to see what we want to remove. This is the most important part. Without seeing it directly under the microscope with a magnification, we are not able to remove the broken instrument. Of course, this is the totally basics, that we need to use the rubber dam isolation. We need to prepare some straight line access, and that means that we need to prepare the access cavity. We need to enlarge and straighten up the canal above the broken file. And for sure, the magnification is necessary for cases with broken files. Without magnification, it is almost impossible. How can we quickly enlarge the canal? You showed the rotary files from MetaBiomed that can create a space above the canal, and they are great instruments. But when the canal is straight and we need to quickly enlarge the canal space above the broken instrument, we can use Moon's Discovery burrs. They are my favorite rotary burrs, and this one is my loved one, because the size of the head of this carbide burr is according to ISO standardization size 40, and this shaft has 34 millimeters long. So under the microscope, we can deeply prepare the canal inside with a huge precision because of the small head of the file. Of course, these files are stainless steel, so they can work only in straight part of the canals. If the canal is curved more than the average, it is not a good idea to use these stainless steel files. We can use some NiTi files or modified NiTi files like E3 Azure, for example, or the MetaBiomed files to create some space above the broken instrument. You also mentioned about blocking the other orifices of the canal. You block it with the flowable dam. I used to use cotton pellets, but as we know, they got some small particles that can roll into our rotating files. So nowadays, instead of cotton pellet, I'm using a Teflon tape when the other canals are opened. I remember about this all the time after I spent 45 minutes of removing the broken files from mesiobuccal canal of lower molar, and it just jumps out from the mesiobuccal canal and goes into the mesiolingual canal. And I spent additional time to remove this file from the mesiolingual canal. So from that time, that moment, I always remember to cover the orifices of surrounding canals when we are removing the broken file. And ultrasonics that we use during this procedure are the same ultrasonics as we use for calculus deposits removal, but we are working in dry conditions. If we want to see something inside the canal must be empty, without any liquid. Of course, the ultrasonics, when they are working in the dry conditions, they are getting the high temperature. So we need to work at low power, and we need to have short working episodes. For me, it's like 1 minute and 30 seconds of working, when my dental surgery assistant is keeping the suction and also air syringe next to the tooth and blowing the air to the operating field. This air has two advantages. First, it removes some dentine debris that I'm cutting with the ultrasonics. The second advantage is to cool down the surrounding dentine. But after 1.5 minutes of working, we need to flush the canal with some irrigant. I'm normally using sodium hypochlorite for this purpose. And we need to dry the canal before the next working session with the ultrasonics. Paper points are not the best idea. Microsuction tips are better idea because paper points can push the broken part of the file deeper in the canal while drying. So the microsuction is better an idea, and I saw, Jenner, on your movie this microsuction tip as well. So we can agree in this point also. And we can have ready-to-use ultrasonic tips like CPR tips, but they are quite expensive and not durable. We can use it once, and also on this movie you present some Terauchi ultrasonic tip that broke inside the canal. I think this Terauchi tip is also not cheap, but because of this economical point, I prefer this kind of the ultrasonics. This is the EndoChuck and removable tips that we can apply here in this EndoChuck. And we can use more aggressive U files, for example. U files in cross-section, they are K files. So they cut not only at the end of it, but also at the sides of it. So we can quickly enlarge the canal above the broken instrument to see this file. But if we want to be more specific, more precise, we can change the U files into Endostar sonic files. They are looking like spreader files. So they are cut only at the sharp edge, the sharp point of this ultrasonic tips. At the sides, they are smooth like spreaders, so they have no ability to cut at the sides. I use it every time to activate the sodium hypochlorite during the final irrigation protocol, but also if I want to remove the surrounding dentine around the broken instrument, I switch from the U file into this more prestigious instrument that is removing only at the dentine at the end of this file. The additional advantage of this Endostar sonic files is that every time I break the file, it breaks like a Gates Glidden burst. So it breaks like 15 or 20 millimeters part. So it is easy to remove. We just take a pliers and remove it from the broken canal. So it's easy. And with this ultrasonic tips, we can remove files just with the ultrasonics. This canal, as you can see, we can compare this case to the case that your first case you present. We got separate two parts of the instruments. It's lentulo spiral inside the canal, and one is located in the apical area. And we got some lesions here. So lesions are the factor that give a lower chance to success if we leave the broken instrument inside the canal. And according to the anatomy of this case, straight canal, I was able to see exactly where is located this broken file and gently remove it from the canal. And on this post-op radiograph, we get a calcium hydroxide paste inside, because sometimes as an endodontist, I'm asked by the general practitioner just to do the removal protocol and prepare the canal, and the general practitioner will finish the case in their office. Also here, the canal, the mesial canal in lower molar with some curvature, so it is not easy to create a straight line access here, but with the modified NiTi files, I can enlarge the canal and then remove it with the sonic files, this broken instrument from the canal. It was quite easy, and as you can see here, I did not demolish the root, the mesial root of this tooth, because this broken part is short. It's like 2.5, maybe 3 millimeters. So it can jump out from the canal just with the ultrasonics, because it is quite easy. But when we want to remove longer instrument, sometimes we need to add some additional tools to the protocol. In this case, you can see also similar situation, lower molar, mesial root, and broken instrument in one of the mesial canals, removed just by ultrasonic forces with the ultrasonic tips. And direct post-op and direct post-op after the root canal treatment. So in these cases, I use only the ultrasonic tips, and to release the broken instrument, I used sonic files. Also, before I present you the knowledge about modified injection needle, let me play you the video with this ultrasonic technique. Quick video how to remove the broken file from the mesiobuccal canal in upper first molar. In this case, I used U files mounted on the endo chat, and you can see here I got the rubber dam isolation, proper cavity preparation, straight line access. We can see the silver point at the end of the canal. This is the broken file, let's say head of the broken file, the coronal portion of the broken file. And then when we release it from surrounding dentin about 1 or 2 millimeters, we can see that it starts to screwing out from the canal. So we can use the ultrasonic tips like a screwdriver and threw it out from the canal. So now I'm continuously adding some ultrasonic forces to the file and doing some rotary movement with the tip while working. And in a second you can see it just disappeared. It disappeared because my dental surgery assistant was continuously blowing the air into the operating area, and when the file jumps out, it was blow out from the pulp chamber and goes directly to the suction. That's why we cannot show the patient the trophy of the broken instrument that we removed. We can just confirm it with the X-ray that the canal is empty and there's no broken instrument anymore inside the canal. But sometimes when the files are longer, and I mean 4-5 millimeters long, we need to apply something like BTR pen. But if we don't have a BTR pen in our office or other system ready to use to remove the broken instrument, we can do the homemade technique with the modified injection needle. So we also need to create a space, enlarge the canal, visualize the broken instrument, and then we need to choose the proper size of the injection needle. We got a plenty and variety of the sizes from 0.5, 0.6, 0.7, 8, 9, etc. So we got a variety of possibilities, and we need to choose as small as possible to fit the broken instrument into the needle space. So it requires some experience with the technique, but normally I start with the file number with the needle size 0.7, and if I see that it's too big, I choose 0.6 and try to fit it, or 0.8 if I see that 0.7 is too small. Then we need to modificate the injection needle, and the modification is that I'm just cutting with the diamond coated rotary burr the sharp edge of the needle. I smooth the edges of the needle, pre-bend the needle, and I'm just trying to fit without any glue, without any cement inside, if the broken instrument that is loose inside the canal is getting into the needle lumen, needle space. If it goes inside, my dental surgery assistant prepared phosphoric cement, the rapid action of the with a rapid setting time, and I'm just with a pecking motion apply 1 millimeter of this phosphoric cement at the end of the needle and place it again at the top of the broken instrument. Then I wait for 1 or 2 minutes to the cement full set and be hard as a rock, and then I remove the broken instrument from inside the canal. So sometimes I do cases like this when I can clearly see after the straightening of access. You can see this dentine triangle is covering the orifice, but after I prepare a straight line access, here we can see the straight line access, I was able to see the broken instrument inside the canal, lose it a little bit with the ultrasonics, and catch it with the injection needle with small size. That was the one shape file from my colleague that sent me the patient and asked me, I'm begging you, Peter, please remove this broken file and I will do the rest of the treatment. And I said, okay, then on the preoperative x-ray, it is in a very difficult area, but I will try to do this removal protocol. And it was not so difficult as I thought. After a few minutes, I was after the procedure with a file cemented inside the needle. This is one of my very first cases of this technique when it was, I think, 11 or 12 years ago when I was trying to do this and learn this technique. Also difficult localization because we got apical third, but we got periapical lesions here. So I straighten up the canal. I lose this broken instrument with the ultrasonics, and then I cement it in the modified injection needle. And you can see this broken instrument and modified injection needle cut. I just cut out the sharp edge, pre-bend it to have a better visualization when I'm working with this needle inside the canal space, and then I just apply a little bit of this phosphoric cement. Why phosphoric cement with a rapid setting time? Because it's cheap, and it also has, as manufacturer says, rapid setting time, but sometimes we need to wait for 2 or 3 minutes to come fully set the material. And the third reason why I'm using phosphoric cement is sometimes we remove just a needle and the phosphoric cement is connected to the broken instrument inside the canal and stays inside the canal lumen. And the phosphoric cement is white, completely white, so we can see under the microscope where is the excess of the cement, and we can remove it with ultrasonic, try again to loosen more the broken instrument, and take a second attempt of the modified injection needle. We can also remove very, very long files with this technique. On this preoperative X-ray, we can see that the one of the mesial canal is fully obturated with separated lentulo. We can see it starts at the orifice levels and ends at the end of the canal. And on the post-op, it's totally empty without any broken instrument. And you can see here on this picture how long part of the lentulo was cemented in the needle space with the phosphoric cement. So it's a great technique because we got a lot of different sizes of the needles, and also it's cheap, predictable. The only disadvantage of this technique is the time that we need to spend waiting for the cement to fully set, because it needs to be fully set, completely set, like it should be hard as a rock. Otherwise, the broken instrument may stay inside the canal, will not go outside with our needle. And last case from this presentation, very long part of the broken instrument, like from the orifice almost to the apical part, also cemented in modified injection needle, and it was good to easy technique to remove it from the canal. Okay, so Jenner, can you tell me, have you tried this modified injection needle technique in your office? And do you have any thoughts about this technique?
The technique looks very interesting because, as you mentioned, it looks very predictable. Having a proper choosing of the cement for grabbing the file, I think that is a key factor, and to wait the proper time as well, because as every practitioner knows, 1 minute in the office seems like an eternity, and the clinician might be just do not want to wait the 3 minutes, for example, and if they attempt to take it out before the cement gets hard, it's going to be a failed technique. So it's very important to wait the proper time, because I think the oxygen that is making the cement to get hard to set, it's not going inside of the root canal, and that's why we need to wait a lot of time. It's a very interesting technique. I have never tried to use it, but I will for sure, because it looks easy to apply. And I say easy because, okay, we will touch this point after. And a cheap technique. Removing a broken instrument is not cheap at all. removing a broken instrument might be very expensive because just one broken ultrasonic tip may cost a lot. And if we broke the tip, that's it. We need to use another tip. And sometimes the procedure cannot provide any profit because of all the armamentarium that we need to use. So how do you have the idea of this technique? It was in one case where you have the idea, you saw it in a lecture. How do you choose the proper cement? You have a different attempts before perfectioning your technique. What's the story?
First, I've read about this technique in some Polish dental magazine, and the authors were my colleagues from the university when I was doing my PhD. So I asked them about the details, and they they modified injection needle in totally other way. They add additional sharp point at the end with the diamond coated burr, and they were just rotating it, waiting that the dentine debris that sharp point is creating will fix the broken instrument inside instead of cement and remove it. It was not easy to do. So I asked them if it's not better to use some glue. For example, any kind of glue that we use at home, or maybe some flow material. But flow material is difficult to set without proper lightning, and inside the canal, inside the needle, it's almost impossible to achieve it. So I tried with different prosthetic cements, and the cheapest one and with the shortest setting time was the phosphoric cement. So I decided it's okay. When you try to cement the crown and you prepare the cement and leave a little bit of the cement on the flat spatula, when it sets totally, it's extremely hard to clean the spatula. So I think the adhesion of the cement to the metal is high, even on the flat spatula. So it will be higher inside the needle with some gravings of the broken instrument. So it will be quite good option. And I tried it, and it was success. So from that time I used this cement for this technique.
I think we have one question related to your technique.
Mm-hmm. So Kiri Marioli asked, what gauge is the needle that you use for the apical third retrieval, and what is the time that you wait for the zinc phosphate cement? The gauge of the needle is related to the size of the broken instrument, and it's no easy guidelines how to choose the size. As I said, it requires some experience with the technique. So I advise you to start with size 0.7, and if this 0.7 will be too big, it will not reach the broken instrument, choose the smaller size. Or if it's too small that the broken instrument doesn't want to go inside the canal, inside the needle lumen, choose the bigger size. And I will give you the tip how many time we need to wait for the total set of the zinc phosphate cement. The rest of the cement that we prepared for this technique, we can grab into small ball of the cement, and we should wait that this ball will be hard as a rock. If it goes like you want to cut the aspirin into halves, so it's hard like an aspirin, that means it totally set, and we can try to remove it from the canal. And also, Tariq Irashed, can we use a composite filling? If it's not only light cured composite, but dual cured composite, we can, but also the time will be long, I think, and the color of the composite filling is more dentine look-like. So if it stays inside the canal, will be more difficult to remove it than the zinc phosphate cement that is just white.
Yes, exactly. It's a very important point to have that in mind, because if the clinician decided to use a dual cure cement, the dual cure cement might be an impediment inside of the root canal in the end. Perhaps they will be able to remove the file, but they will have the composite or the resin inside. So it's important to have that in mind. What do you think about the learning curve? As we have seen, I think that the technique and the protocol for removing files is very personalized. I think that every clinician have a specific tip or a specific tool. It took me some time. My advice is not to work on the learning curve in patients. It's better to work in extracted teeth always. Otherwise, we can create a disaster, and it's not an easy to overcome learning curve. It takes some time, and not all the practitioners are willing to take that time for training themselves. So what do you think? Do you have any advice to overcome that learning curve that I think is hardest ones to overcome in dentistry, in endodontics?
Yeah, I agree with you. I spent a lot of time on extracted human teeth mounted in some kind of holder, and under the microscope try how to remove it. And then the learning curve is still not enough, because every case is totally different. It mostly depends where the broken file is located. If it's behind the abrupt curvature, I'm not trying to remove the broken instrument, as you present in the first case. That was the case that I will also do the same decision. But decision making is also some. We need to have some more knowledge and personal experience to have this knowledge how to choose the proper decision. It is, I think, in this case, the most difficult to choose the proper decision, because, as I said, every case is totally different, and we need to analyze all pros and cons of the case.
Great. So I think I would like to finish my part giving some advices. So the power that the practitioner selects on the ultrasonic unit is very important for not to break the ultrasonic tips. I learned this from my good friend Alexandre Capelli. He have a company. They are dedicated to manufacture ultrasonic tips. And for removing files, and I think that we cannot go above the 20% of the power that the ultrasonic unit can provide. For the Terauchi tips, for example, I cannot go above 10%. If I go above 10%, it will break immediately. And you mentioned a very important tip is do not keep a continuous application of force. It should be a pulse application, like activate the tip, let it work for 1 second, release, activate, release, activate, and in that way, the tips will last much more time. Very important to have that in mind. And another advice, and let me know your opinion as well. I think that trying to remove a file without a microscope is not advisable. It's too risky and almost impossible.
Yes, maybe some loops can be helpful when the broken file is 1 or 2 millimeters underneath the orifice level, and you can see with the loops without the same axis of light the broken instrument, okay, you can give it a try. But if it's deeper inside the canal, microscope is mandatory for the case.
Exactly. So, any final comments, Pedrito?
I think we can just say thank you for your attention. It was a very nice hour and 8 minutes to spend with you, and very nice cases. I'm glad to see you. I hope we will see live in some kind of courses in the future. So it was a pleasure, and thank you very much for this conversation.
Thank you. It was a pleasure as well. I hope to see you soon live in the near future. Take care, my friend, and thank you everybody for watching this session. Bye.
So greetings from Poland and Guatemala. Cheers.
Cheers.